welcome our presenter for today's session, Priyamvada BP, a third year MBBS student. Thank you all for being here. Let's look forward to an engaging and enriching session. Over to you, Priyamvada.
All right. So today we're discussing a paper that is titled The Effect of Sitagliptin versus Placebo on Bone Mineralization in Women with Type 2 Diabetes. This RCT has been called the SLowDOWN trial, which stands for Sitagliptin in Diabetes for Osteoporosis in Women. This has been published in a journal called BMC Medicine, and its impact factor is 9.4. Impact factor is a metric to measure the standard and quality of a journal. This is basically calculated by the number of times the article was published in the last 2 years, published was cited by index journals, divided by the number of citable items in the last 2 years. So we look at the list of authors here and we consider guest authors and ghost authors. So what are each of them? Guest authors or gift authors are basically individuals who are listed as authors without having made a substantial contribution to the research or manuscript. Ghost authors are individuals who have made significant contributions but are not acknowledged or listed as authors. So in this paper,
Volume ಕಡಿಮೆ ಕರೆನ ವಾಲ್ಯೂಮ್ ಕಡಿಮೆ ಕರೆನ ನಾನು
so in can everyone please mute? So in this paper, we can see that there are no highly influential figures. So the number of guest authors is having guest authors is unlikely. Yes. And here is a list of all the authors and their profile. Coming to the flow of this meet, we will be discussing it under introduction, overview, statistics. We'll critically appraise the article, then move on to the results and conclude with summary and final takeaways. Throughout the duration of this presentation, I will be using the consort checklist to help with assessing the RCT. So first up, we talk about the title. The title clearly identifies the study as a randomized clinical trial, and we usually break it down into PICO. P, which is population, that is women with type 2 diabetes mellitus. I is intervention, which is here oral sitagliptin. C is the control. It is a placebo control trial, which means that we are comparing with placebos. And O is the outcomes, which refers to improved bone mineralization. When we evaluate the abstract, the keywords are adequately mentioned, and it has a structured summary of background, methods, results, conclusions, and trial registration. Let's break into this one by one. We first look at the abstract, and we see that throughout the study, there were 132 patients who were enrolled, randomized, and divided into groups of 66, each into sitagliptin and placebo groups. They were followed up for 52 weeks and analyzed at 24 and 52 weeks for total proximal femur bone mineralization density. This is also called the T-score. So what were the results according to the abstract? We have primary outcomes and secondary outcomes. In the primary outcomes, we see that the sitagliptin group showed significant preservation of bone health, whereas the placebo group noted reduced bone mineral density. The secondary outcomes noted that there were reduced levels of bone inflammatory mediators in the sitagliptin group. However, there were no differences in glucose-controlled serious adverse events, and mild to moderate adverse events are illustrated later. In conclusion, sitagliptin treatment was associated with preservation of total hip T-score. However, bone sites or turnover markers did not have any consistent effects. This gives us an insight into potential additional benefit of sitagliptin beyond blood glucose control. However, longer-term studies are required for confirmation. So, let's delve into this inch by inch. Diabetes mellitus is a metabolic disorder which is characterized by chronic hyperglycemia. What is the epidemiology? According to the International Diabetes Federation, the global prevalence is more than 530 million, with a slightly male preponderance. Risk factors include genetic predisposition, obesity, physical inactivity, age, and stress. The pathophysiology basically is an insulin resistance in target tissues along with beta cell dysfunction. So, what are the goals of anti-diabetic therapy? There are mainly 3 goals apart from insulin replacement. That is, number 1 is enhancing insulin secretion. The second one is overcoming insulin resistance. And there are other drugs which will inhibit other enzymes which are involved in glucose metabolism and absorption. So here we focus on this group of drugs called dipeptidyl peptidase 4 (DPP4) inhibitors. Examples including sitagliptin, saxagliptin, etc. So, how exactly do these guys work? Dipeptidyl peptidase 4 or DPP4 is an enzyme which breaks down two things. One is GLP-1, which is glucagon like peptide 1, and the second thing is GIP, which is glucose dependent insulinotropic peptide. So what happens is, in the gut, whenever you have any food, there are certain incretins, which is GLP and GIP, which are secreted. These incretins will act on the beta cells in the islet of Langerhans in the pancreas, and this will enhance insulin secretion. So what happens when there is when there is when there are DPP4 inhibitors is that they prevent the breakdown of incretins. So increased incretin levels will lead to increased insulin secretion, decreased glucagon, both of which will collectively result in a decreased hepatic glucose output and thus decreased blood glucose. So, what are the pharmacological effects of DPP4 inhibitors on the bone? Because that's what this study talks about. So, these incretins have anabolic effects on the bone by decreasing bone resorption, increasing osteoblast differentiation, and it improves glucose metabolism and reduces inflammation, all three of which help in bone mineral density maintenance. So, all of this has been mentioned in the article's background, giving us a solid explanation and rationale behind conducting the study. Let's now move on to the objectives. The primary objective is to test the superiority. Let's break down each of these words. Why is it called a superiority, a superior RCT? It's anytime you want to compare A with B and establish whether A's efficacy or safety is more superior to B, it's called a superiority trial. Here we are comparing two groups. Group 1 is 100 mg sitagliptin plus metformin versus placebo plus metformin. So we're seeing how effective sitagliptin is in preserving bone mineral density, which we will estimate by something called DXA, which is dual energy X-ray absorptiometry. We will talk about this later on. This is done at two sites, which is the lumbar spine and the neck of femur. Then we talk about the secondary objectives. There are three of them. One is we're looking at an association between the circulating DPP4 and serum markers of bone metabolism, which are listed later. Second, we are again seeing if the circulating DPP4 activity is associated with impaired vitamin D availability. And finally, we're looking at its effect with systemic markers of inflammation. So here we see that specific objectives have been established. Moving on to the methodology. We look at each of these words in detail and see what they mean. Multi-center. This study was conducted in two centers, both of which are a part of Sapienza University in Italy, Rome, and Italy, Rome. And next one is double-blind. Both the participants and the research team, that is investigators, clinical staff, and lab staff, will not know which participants are receiving sitagliptin and which are receiving placebo. Randomized basically means that the participants are assigned randomly to either the sitagliptin group or the placebo group, not by choice or researcher decision. Finally, parallel group design. It's called a parallel group because both the groups, sitagliptin and placebo, will run in parallel throughout the study rather than switching the treatment, which will as would occur in a crossover trial. Okay, so sorry, is everyone still able to see my screen? Okay, so finally, we talk about placebo control trial. This means that we are comparing sitagliptin to a placebo. Let's now look at the inclusion and exclusion criteria. The inclusion criteria include female participants above the age of 18 years who are diagnosed with type 2 diabetes mellitus with normal BMI and body weight below 120. HbA1c should be less than 7.5, which indicates stable glycemic control, and they should be on metformin therapy 12 weeks or more. We also include postmenopausal, surgically sterilized, or those who are using effective contraception. Exclusion criteria include hepatic, renal, or thyroid disorders, non-metforming antidiabetic agents, substance abuse, inability to provide consent, and use of medications which are affecting bone metabolism. So, what are the limitations in the inclusion and exclusion criteria? First, let's look at the population. Only women above the age of 18 years are considered. However, an improvement would be to include men or have separate sex stratified arms. Why is this important? Because this data generalizability basically refers to its ability to be applied to another population. So, this data cannot be applied to males. Baseline bone mineral density. This is not stratified. Stratification basically means grouping the participants into different strata, so or groups. So here, if we would have included cutoff values for bone mineral density and grouped each of them into different groups, we could have avoided bias. The third one is vitamin D or calcium. Again, it's not a standardized approach where serum level cutoffs were not mentioned, so any deficiency could be a potential confounder. Diabetes duration works in the same way because chronic complications can themselves lead to a decrease in bone mineral density. And finally, we talk about fall risk, which is not assessed. They've included fracture risk. However, fall risk will also impact the bone mineral density in practice. Now let's look at the methodology. So, in a sense, 133 patients were assessed for eligibility, of which one did not meet the inclusion, so 132 patients were enrolled. They underwent randomization through permuted block randomization. What does that mean? So, it means that participants are put into small blocks like mini groups before randomizing, so that each block has an equal number of people in each treatment arm. Why is this done? To make sure that the groups will stay balanced throughout the trial, not just at the end. Second one, also in randomization, there is something called allocation ratio, which is usually for every one person who is assigned to group A, how many people are assigned to group B. So while it is explicitly not mentioned in the paper, it is assumed that a 1:1 allocation was followed since there was equal division of the population. Second one is blinding. Blinding double blind basically means, like we discussed earlier, both the researcher along with the patient's investigators, lab staff, none of them know who is receiving sitagliptin and who is receiving placebo. And emergency unblinding was allowed. This basically means if there was any adverse event, then then unblinding would be performed, and ITT or intention to treat or per protocol analysis would be performed accordingly. Finally, there's the intervention phase, which was 52 weeks or a year in duration. Medication, which is sitagliptin, was dispensed at baseline and at 24 weeks. And to check whether the medication was followed, blister returns, that is the pack returns, were checked. Then we talk about the assessments. So there were a group of clinical assessments, bone markers, inflammatory markers, vitamin D and DPP4 activity that was measured. Primary endpoint was basically change in bone mineral density. What were the sites? Again, lumbar spine and femoral neck, and this was measured by DXA. The secondary analysis included the trabecular bone score. So, what is this? This is a measurement from a bone scan, that is DXA, that tells us how good the bone quality and structure is. It's not just bone density. So, a higher TBS would mean stronger, healthier bone microarchitecture. Then we talk about correlations between DPP4, vitamin D inflammation, and bone markers, and statistical methods, mixed models, Pearson or Pearson-Spearman correlations. What does that mean? So mixed model basically means you have repeated measurements like bone density at 0, 24, and 52 weeks. It can handle missing data and differences between participants, making the analysis more accurate. What is Pearson-Spearman correlations? They both measure how strongly two things are correlated. So Pearson will measure for data that follows a normal linear pattern, and Spearman will measure for data that don't follow a normal pattern. So it's called rank based. Example is a correlation between age and bone density. age and bone density. Next, we talk about the data analysis. Here we have some new terms again: effect size, intention to treat, and per protocol analysis. What does that mean? So, effect size basically it tells you how big the difference between the groups is, not just whether it is statistically significant. So, a larger effect would mean more meaningful difference in real life or clinically more different. And power estimation basically means that the chance that your study can detect a real difference. Usually, studies will aim for 80 to 90% power. Now, the interesting bit here is intention to treat versus per protocol analysis. Usually, RCTs will perform either of these analyses. ITT includes everyone who was randomized, even if they are dropped out or didn't take the treatment properly. So, per protocol analysis, on the other hand, will include only those who followed through the study exactly. So, the difference is that intention to treat will reflect real world effectiveness, but per protocol analysis will actually reflect the true efficacy under ideal conditions. So, sorry, under ideal conditions. So, we look at limitations in the methodology now. Here, it was mentioned that permuted block was performed, but the block size was not specified. So, what is the block size? The number of participants in each group before randomizing. Example: a block size of 4 will mean that 4 participants are randomized at a time. So, 2 to each group in a 1:1 trial. And what is operator bias? When the person performing the measurements, like the DXA scans, will unintentionally influence the results. For example, if he knows that a person is taking a placebo, then he is biased to give a lesser bone mineral density value. This is prevented by blinding and standardized procedures. So, allocation ratio, like we discussed, is not mentioned. Blinding, it was stated that both the placebo and the sitagliptin pills were identical. However, based on taste or smell, if partial unblinding had occurred, it could introduce a performance bias. Performance bias basically means when the person who is taking the pill gives responses according to whether they know if they've gotten placebo or sitagliptin. Follow-up duration was only 52 weeks. This is very limited and it's inadequate for establishing biochemical changes. So finally, power calculation was based on assumed effect size. So this RCT is the first of its kind, and that's why there was a lack of prior standard data to base the power size calculation on. However, this will in turn reduce the accuracy of sample size justification. Confounding factors like vitamin D supplementation, calcium intake, menopause duration were also not included. Measurement tools that was used was DXA, like we discussed earlier, but a single technician was used, so operator bias is possible and reproducibility is limited. Unblinding conditions referred to protocol violation, but what these protocol violations were not mentioned. Finally, the clinical endpoints were only bone mineral density and biochemical markers. However, fracture risk or functional bone strength were not really measured, and these ones are the ones that are clinically important. We now move on to results. So, in conclusion, of the 132 patients who were randomized, 66 into each group. In the placebo group, 15 discontinued treatment because of the reasons mentioned in the flowchart. 51 were undergoing treatment, and that's why they were included in the per protocol analysis, like we discussed earlier. However, in the sitagliptin group, 12 discontinued treatment, and 54 were included in the PP analysis. So, what is the strength? This RCT gives us a detailed participant flow diagram, and the losses and exclusions after randomization are also mentioned. However, the recruitment period and the dates are not mentioned either in the flowchart or in the paper itself. Next, we talk about the results. So, I know this may look like huge tables to you, but our takeaway from this is basically that number one, baseline characteristics are illustrated in detail, and number two, let's discuss a little bit on what is p-value. A look at the p-value. So, what is the p-value? This basically tells you how likely it is that the results happened by chance. So if the p is less than 0.05, the difference is considered as statistically significant. But it doesn't tell you if the difference is clinically important. So that's what the p-value is. Another value that I'd like to discuss here is the confidence interval. Confidence interval is basically a range of values that shows where the true result probably lies. So, for example, you have a mean difference of 0.11 and 95% confidence interval, say from 0.03 to 0.19, like as given here, will mean that we're 95% sure that the real difference is between 0.03 and 0.19. This is basically to avoid the bias that arises because of the presence of mean. If the confidence interval doesn't include zero, then the result is considered significant. Um, Coming to the primary endpoint table, which is the ITT population, intention to treat. Here again, as discussed, all of the participants who were randomized were included in this table. And over here, let's just look at the p-value. It is 0.29, 0.43, 0.11. So each of this tells us how clinically significant the data is. And the confidence interval, like we discussed, is basically 95% confidence interval means that there's a 95% chance that the actual value will lie in between these two. So here we're basically looking at the bone mineral density at the femur neck, which is obtained from the DXA. We are also looking at the T-score and the same parameters at the lumbar spine as well. Then we look at the trabecular bone score, which was discussed earlier. Later, we talk about the safety and tolerability of the drug. So, sitagliptin is a well tolerated drug. However, in this RCT, they reported 5 adverse events, of which 2 were mild, 2 were moderate, and 1 was severe, the details of which are mentioned here. Then we talk about the study limitations, which has actually been included in the study itself. Including the limitations in the study is a strength, but let's discuss this. So, number one is that it has limited statistical significance because only the total femur T score will have a significant difference. The other bone parameters, biochemical markers, were not significantly changed. And this is likely due to the fact that it was a short period duration of only 52 weeks, whereas other bone parameters will require a longer duration to change. Second one is that it had a small sample size, also because there was no standard data that earlier based on which they could calculate their sample size, which is why a small sample size will not be able to detect subtle differences in bone metabolism. Restricted population, it included only women with type 2 diabetes on metformin therapy. So this will limit the external validity to men or those on other anti-diabetic regimens. Then we talk about biomarker insensitivity, like we discussed. So the markers that were used were systemic markers, but local skeletal effects might not be reflected by these markers. Additionally, other lifestyle factors like physical activity, dietary calcium, or vitamin D intake were also not considered. Long-term safety outcomes were not measured, so that's why there's limited adverse event reporting, and there's also no bone quality or fracture risk beyond the bone mineral density measurements. External validity or generalizability basically refers to how much can you apply these findings to other geographical settings or patients. This was explicitly stated, and this mentions that the results will apply mainly to women with type 2 diabetes. Finally, how do we interpret this RCT? They interpret that sitagliptin is potentially preserving the femoral bone mineral density. They also discuss biological plausibility in the background by talking about DPP inhibition and cytokine modulation, like we discussed. While we compare with past meta-analysis, we see that there is both a protective effects and inconclusive evidence that has surfaced. So this RCT puts a halt to that. It also acknowledges neutral results for other endpoints, which was the bone markers, again, due to the short duration of the study. Finally, we talk about the registration and funding, both of which have been mentioned in the acknowledgements and registration section, respectively. Final takeaways are that the SLowDOWN trial is the first RCT to evaluate sitagliptin's effect on bone health in women with type 2 DM. It also showed preservation of femur density and was safe and well tolerated. Further, larger studies are needed to confirm its long-term relevance. I would like to conclude by saying that research is not just asking one question and trying to prove your point, right? It is, in fact, asking multiple questions and arriving at a conclusion that leads to breakthroughs. So, thank you.
Thank you, Priyamvada, for that. So I believe that Dr. Pradeep sir has prepared some questions. So can we move forward with that, sir?
Uh, I will take those in the last, like while concluding.
Okay, sir.
Yeah, yeah.
Then I invite Prashant sir to kindly share your views.
Congratulations, Priyambada, on that very lucid presentation. And yeah, along with the paper itself, she's also giving out a lot of information about research methodology and types of studies. And I think the students who have newly joined the club will benefit a lot from that. So I'm sure a lot of clinical information will come from Dr. Pradeep and Dr. Aradhana. I would just like to say that the new joinee should also focus on understanding the research methodology, which will help you design your own studies in a better manner and also write up and present them in a better manner. So other than, I don't have much to add. So I think we will better hear from Dr. Aradhana and Dr. Pradeep on this.
So Dr. Aradhana ma'am had to leave, I think. So Pradeep sir, can you please share your views?
Yeah, you can hear me, right?
Yes, sir.
Yeah, yeah. Fine. Yeah, it's presented very well. You have done justice to the journal club. No, no, you don't share it. Like I have other things I will do later. Okay. I'll tell you when to share. Yeah. So yeah, everyone has to understand that the journal club is mainly about how the study is conducted. Because see, as a clinical medicine person, so what we need, see, this is the final thing. We want to treat patients. So we should know whether this study is correct or not. That is the main purpose of discussion of journal club. So that she has done very well. Okay, so I'll just ask few questions to Priyamvada. Later we'll have a poll for other students also. And meanwhile, we'll be learning through that. Okay, it's very well presented. Uh, so to you, Priyamvada, like you told, statistically significant is not clinically significant. So how do you make it clinically significant? Because if clinically it is not significant, then what is the purpose of knowing that study? So can you tell something on that?
Yes, sir. So there are multiple answers to this question. The first, of course, lies in the type of study itself. So a lot of studies like observational studies or prospective cohort studies can be statistically significant, but they need not necessarily be clinically significant. So the way we measure this is by using the p-value. So if the p-value is less than 0.05, then we consider statistical significance. But clinical significance, we will look at the effect size, the magnitude of improvement. Was there a drastic improvement or a lesser improvement? And we see if this is generalizable to our population. So, how to make the result clinically significant is number one, have a meaningful effect size. So, the observed change should be big enough to matter. Second one is we use like patient relevant outcomes. For example, over here, if they had used fracture reduction or symptom relief, quality of life, then it would be more clinically significant. Other ways we can do this is by increasing the study power and by following proper design. And yes, sir, that's
Yeah. That is precise answer. So like you can like include fracture risk. So but fracture risk needs at least 3 to 5 years of follow-up. So this study just mentions mainly of biochemical changes which can be measured in a year, but clinical significance needs more time, as you mentioned. Yeah, fine. Then can you like tell like you told you can we should ask multiple questions, not single question. But is it possible to answer multiple questions in a single research?
So, depending on the type of statistical analysis that we're using, we can answer single or multiple questions. So, over here, they have used a mixed model, which is why they're able to ask multiple, exactly 4 questions and able to answer them as well. But if we use other simple tests like just odds ratio or just for example, I am not that well versed with statistics, but say if we use simpler tests, then we will be able to answer only a limited number of questions.
Usually single research, like we try to get only question as specific as possible. See, for example, this trial also, you have checked sex only one drug and in one population. So I think, to my knowledge, like we can answer only one question from one research, or else it becomes like you may later add secondary. See, in this also they have written primary outcome, secondary outcome, but you keep one primary outcome as a most important thing. I think multiple questions will dilute the study, but this is my understanding. Okay, then like, are type 1 diabetes patients excluded in the study? Because you told the age is more than 18 years.
Yes, sir. It's only for type 2 diabetes mellitus.
Okay, it's mentioned in the exclusion because I couldn't find that word. That's why.
Sir, actually, in the title itself, they mentioned that it's for women with type 2 diabetes mellitus.
Okay.
Yes, sir.
Yeah, still it is why what is the importance of mentioning it? Like, I mean, why what is the importance of type 1 diabetes on bone compared to type 2 diabetes?
Sir, so in my limited
Can
clinical
you switch
knowledge,
on video if it's okay for you?
yes, sir.
Because I'm talking to a screen, I feel.
Sorry, sir. I was just worried my voice might break. So yeah,
Yeah,
so
continue.
type 1 diabetes is basically an autoimmune condition, right? So whenever there is an autoimmune condition, inflammatory markers in the body are usually elevated. So when there is an elevation of these inflammatory markers, bone mineral density is likely to decrease, which is why type 1 diabetes mellitus itself could be uh, a contributory factor for a decrease in bone mineral density. So it is important that we exclude them from this trial.
You know how different it is from type 2 diabetes.
So
Both are,
type 1,
both are related to hyperglycemia. So how
yes.
different the effect on bone?
Effect on bone is different because, again, so in type 2 we will not have inflammatory markers which are high. We i mean there will be inflammatory markers because of hyperglycemia, but in autoimmune conditions basal inflammatory markers will also be elevated, which is why bone health will be impacted, sir. In fact, besides the risk factors is all the risk profile is also different. So for a type 2 diabetes mellitus, we're looking at people who with
No, I'm not going for all those things. I'm asking you the like in type 1 diabetes, some type 2 diabetes, and the bone effect. That is the crux of your study. Like, then only you can understand what kind of drugs will help. So is there a difference, like, uh, or it is different? It is same. The effect of type 1 diabetes. For example, I want to conduct a study on type 1 diabetes. Can I just remove the type 2 and then conduct in these patients and add insulin instead of sitagliptin?
no,
Like,
sir.
that's what
The
I'm
reason
asking. Like, how type 1 effect on bone is different from type 2 diabetes. I'm not asking about type 1, type 2 diabetes difference, particular to the bone.
I'm not sure how type 1 and type 2 differ, sir, but I
So
can
you tell it is
answer that.
same. You think is it same?
No, sir. But the reason we can't use insulin instead of sitagliptin is because sitagliptin we are using not only because it's an anti-diabetic drug, but because it's the DPP-4 inhibitor. And like we discussed, DPP-4 has effects on bone resorption through osteogenic differentiation and decrease in other bone osteoclastic enzymes. So that's why we're using sitagliptin instead of insulin. So that way, insulin would not have had an effect. Whether type 1 or type 2 diabetes, how to differentiate that, I'm not sure.
Like, is insulin protective for bone or not protective for bone?
It's not, sir.
No, it is. It is. Insulin is protective for bone. So you need estrogen. That's why postmenopausal there is a chance of osteoporosis. And then insulin is also, it's an anabolic hormone. As it, see, insulin helps in growth of all the okay, yeah. Yeah, insulin helps for all organs, to grow, like fat as well as, so muscle building. So all these things insulin will help. So it will help bone also. Okay, like incretins help in bone, insulin also helps. So basically, what I expected is, like, normally, what is the main? You will be knowing the main pathway for bone. That is, one is parathyroid hormone, one is calcitonin, one is vitamin D. These are the ones which play a major role. But this insulin and then incretins, estrogen, these play and inflammatory markers also will play. So there are two terms actually. There's something called quality of bone and quantity of bone. That is a very important thing you should understand when you treat these disorders. So do you know the difference between quality of bone and quantity of bone?
Sir, bone mineral density would refer to quantity of bone, but quality of bone has other parameters that we assess it with. I'm not sure what they are though.
Yeah. So now I'll just ask you, like, if osteoporosis, you heard of osteoporosis?
Yes, sir.
Yeah. So is it the quantity or quality?
So quantity of bone is decreasing.
So in your study, what like your drug type 2 diabetes is going to affect quality or quantity?
This was targeted towards osteoporosis in women, so it affects quantity, sir.
So that is not like it is partially correct. So type 1 diabetes affects quantity. Type 2 diabetes affects quality. Okay, because as child grows, they need to build up. Okay, so quality of it's very simple. Like you construct a home, so you have quality. You're constructed with some quantity of bricks. Okay, but how well you cement, how well you put, like you have put bricks, but if you have put in a wrong alignment, they won't sustain. So that implies quality. Okay, for our bone, so in type 1 diabetes, the more problem is with the quantity. Okay, so at the end of the day, both will increase fracture risk. Okay, but type 2 diabetes is more of quality of bone. Actually, some studies have shown that the bone mineral density is actually high, which tells the quantity in some diabetics, because diabetics initial phase there will be hyperinsulinemia, right? So
Right,
it
sir.
is anabolic hormone. So somewhere it will increase, but although the bone is very like has more calcium and maybe more, but the repair continuous see bone is active. See, there will be understanding that when there is more calcium, there is more strong bone. It is not like that. Okay, bone has to undergo bone turnover. That means every day it has to undergo resorption as well as absorption. So that is when it will be strong. So that mechanism will get altered in quality of bone effects. So both will cause fracture. But in type 2 diabetes, as it is more of bone quality of the bone mineral density by usually we check DEXA scan will underestimate the fracture risk. So when you calculate fracture risk, you need to. That's why in this study they specifically use the T score for the hip. Okay, so they want to know about the quality of the bone. So that is one thing I wanted to add. And you know what is triple blinding? You talked about blinding. Do you know anything about triple blinding?
So the investigators, patients, attenders, all of them will be blinded to.
No, there are only three blindings. Okay, like you are telling so many names. There are only three blindings: single blind, double blind, triple blind. So, so basically the analyst, the data analyst also won't know that.
Right,
Okay,
sir.
if that person knows, then see there are two parties. One is the patient party, one is the investigation
Yes, sir.
party, and one is the data analyst. So if only one is blinded, it's single, two, three, like that. Okay, fine. Yeah. Yeah, like a journal clinic, general clinically, how do we choose a diabetic drug? A patient comes to me in a clinic. How do I choose a diabetic drug? After that, I'll proceed to how this study I'll implement in my uh, OPD.
Sir, so
Briefly, it is a very big topic like to discuss like how to choose a diabetic drug. Just give me a brief idea. Like a patient comes to me, I will know HbA1c is high. He is a diabetic. Like how do I decide a diabetic drug?
okay, sir. First of all,
Pharmacology is over, right? Why? Pharmacology is over.
yes, sir. Yes, sir.
Yeah.
So first of all, we differentiate between type 1 and type 2 by
Yeah,
seeing.
that is all there. Patient is type 2 diabetes. He has come for you. You want to start oral drugs. Okay, not
Oral.
insulin. You are starting oral drugs. How are you going to choose?
So the first line drug is usually metformin, and if the patient's HbA1c levels are not controlled even on metformin, so we aim to have a glycemic control of HbA1c less than 7 in a diabetic patient. However, if it's not being controlled, then we look at other drugs, especially those that will decrease insulin resistance, because so those are two clusters of drugs. Um, Decreasing insulin resistance. One is
Okay,
bicarbonate.
fine. It's okay. Don't go to the particulars. So you're telling you'll choose metformin for all. Like whoever comes, I'll keep starting metformin. That is what you're telling. This,
Yes, sir. We
yeah,
start with
yeah.
metformin and then build on to other OHs.
Is this what your latest book tells? Like this is when I was in your stage. I was third year. It is 5 years ago. Now it is changed. Okay. So it is your choice, doctor's choice. Okay, because drugs are very well studied. So it's very simple. See, if you know pharmacological, see, first year and second year subjects are very, very important. Even now I'm realizing every day in and day out. Okay. So very simple. They taught you in pharmacology now. So every drug you choose based on benefit and risk. These are two main things. Okay. First important is risk, then benefit. If there is a risk, you don't even do the study. First they'll do a animal study, and then if there is a lot of risk, they don't even do a study for. They don't even consider it. So first we should know the risks of the drug. That is very important. So when you choose sitagliptin, okay, what is a very major side adverse effect which can happen? Like very serious adverse event which can happen. It didn't happen in this study.
I'm not sure, sir.
Yeah, yeah. They tell like Steven Johnson syndrome something. It's a very hypersensitive reaction. So some things like that. So we see, and there are also reports of pancreatitis. Okay, but it's all mixed. We don't know. Like there will be in side effects also. We commonly see uh, common side effects and serious side effects. So common side effects in this will be usually URTI symptoms like that. They'll have like that. So first we see the risks, and then we see the benefit. Okay, to the diabetic drugs, currently we see one diabetic HbA1c reduction. Okay, that is first important thing. How much it is effective. So we divide based on. I'm telling based on latest American Diabetic Association guidelines. Okay, so first we see how much HbA1c reduction is required, and even before that we see first whether patient is having any end organ damage, because as you know most of the diabetics in our like most of the diabetics who are not well, they don't not well educated, they come in a later stage, so they come with complications. So any cardiovascular problem or any kidney disease, heart disease, stroke, so these are the first thing you see. So first, so if those are there, so you choose SGLT2 inhibitors, you choose then a GLP and agonist. So this is the first. These have shown so much benefit in those patients. So it's not about metformin. No more it is a metformin the first choice. Okay. So you
Right, sir.
start either SGLT2 inhibitors like dapagliflozin, or you start like semaglutide is a GLP agonist. So we start that. Okay. So if they don't have these problems, then you proceed to what I'm going to tell next. So first you check these risks. If they have such patient is like in this study, we have checked young women who are moderate hyperglycemia with no problems. They are as healthy as us. Only biochemical changes are there, right? So such patients are taken. In these patients, once you have ruled out that, now you have so many drugs we have. So now we choose based on mainly three components. One is whether there is how much HbA1c reduction is required in my patient, how much control I want. Number two, how like is there any weight gain? Weight gain is very important for a diabetic because obesity and diabetes are like friends. Now there is a new term called diabesity. If you want to do some research, okay, in ICMR you can do research. You can use this fancy word right now, diabesity. So so one next thing we see is weight gain. Okay. And the next thing we see is hypoglycemia risk. These three are the main things we see. Even if you see ADI recommendation, that picture. So these are three things. Based on these three, you choose. Okay. So if the patient is very elderly, I don't want even one chance of hypoglycemia, I won't choose sulfonylureas because they have highest hypoglycemia risk. See, you may find what I'm telling is too much for you, but I'm telling so that when you study, you give importance to these things. Okay, because whatever you study, if you study, you should be able to apply it to the real
Clinical.
world. That is the main purpose of why I'm there here. Okay, so so these three are the things you see. Now, where does sitagliptin stand in these things? You have idea? Or you want
Yes,
me
sir.
to tell?
So, sitagliptin, it does not cause hypoglycemia. Second one, coming to weight gain, it has not been known to cause weight gain as well. And the third parameter was, sorry, sir, the third parameter was,
One HbA1c reduction.
Yes, so HbA1c reduction also, even in this study as well as a previous study, sitagliptin has been effective in reducing HbA1c.
Yeah,
What
yeah.
everyone thinks.
HbA1c reduction means there are drugs which cause very good HbA1c reduction, mild, moderate. So it is under the mild. Okay. So usually in such patients, like very healthy patients, I'm telling you when I will choose this DPP4 inhibitors. We commonly in BMCRI, vildagliptin is freely available in our pharmacy. So generally we choose when patient is young and with no other complications. Okay, even if it is old, patient is having no complications like other diabetic complications, and we need moderate HbA1c reduction and metformin is added but no control. Then we use vildagliptin in uh, our OPD situation. Okay, so you got it right, what I told?
Yes, sir.
Yeah, fine. So now I'll ask one simple question just to test your pharmacological basis. Can we give a patient sitagliptin with semaglutide?
Sir, both of them. So sitagliptin is a DPP4
No, no,
inhibitor.
like one patient has come, he's taking semaglutide. It is costly anyway. So it is a GLP-1 receptor agonist. So it is not controlled. So I want to add second drug. Can I add sitagliptin?
Sir, if it's anyways a GLP-1 receptor agonist, and sorry, GLP-1 receptor agonist, what it's basically doing is that it's increasing GLP activity. But this one is a DPP4 inhibitor, so it's basically decreasing the breakdown of GLP. So if we club both of this together, it will be a synergistic effect where you will have more GLP as well as more receptor
So
activity as well.
you will, as a doctor, you will prescribe. That's what you're telling.
So theoretically, it makes sense.
No, no, actually, mechanism of action is almost same. There'll be no much use. That's what like it is told. Like same mechanism. You should never add same mechanism. You should not add. See, you're telling it is little different mechanism, but at the end of the day, it is incretin effect. You won't combine AC inhibitors with ARBs, right?
Right.
Telmisartan with enlorapril. So it is same. You should not add. Okay.
Right, sir.
Just because one medical rep will come and show you the same study, sitagliptin showing benefit, you give because most of the elderly people will have osteoporosis. Okay, so you will tend to give this thing. Now, another one important question I want to ask, like, should we keep bone health in mind when you start anti-diabetic drugs?
If it's for an old patient, especially a postmenopausal woman, then we need to keep bone health in mind. If they have any other concomitant medical conditions, osteoporosis, osteomalacia, or if they have like prolonged vitamin D deficiency, hypocalcemia, then sir, bone health will play a role.
Yeah, till now we didn't follow it, okay, because no drug has proven any benefit. Okay, okay. So like superiority, non-inferiority trials you are telling, no, like we didn't find much, but we have found one drug which is causing more fractures. It is proven, well proven. So I always teach to my juniors, like first learn what not to do. That is the most important part throughout your life. Then you learn what to do. Okay. So which drug you should never give in a patient, elderly who already has osteoporosis?
Sir,
Which group of drugs? Which group
acar,
of drugs?
acarbose, voglibose.
Yeah, and participants can chart and like can put in the chart if you know. I'll give you some 10 seconds. I'll conclude in another 5 minutes, Yashraj. Is it okay?
It's fine, sir. Take your time, sir.
Yeah, yeah. Well, someone answered. Yeah, these glitter zones. Okay, what are glitter zones? Which group? Which group? Priyam, like glitter zones.
Sir, what?
Your friends have messaged answer. Glitter zones.
Yes,
Which
sir.
group it belongs to?
I'm drawing a blank right now. I have it here though.
It's okay. It's okay. No problem. See, learning is always a continuous process. It's
Sir, it's a part of
thiazolidinones. Okay.
PPAR
Okay.
gamma activators. Yes, sir.
Yeah. So this causes almost 30 to 60% risk of fractures is there. The studies have there they have compared with fracture risk directly. So you should never give it. And why anyone knows like or else I'll only tell why it causes fractures. If you know, then you can correlate whether this can happen with this drug. Yeah.
It's a PPR gamma agonists.
So That is a mechanism of action, like how it causes fractures. Fine. So basically, there's thiazolidines, they act at the level of adipose tissue. Okay. Right now, see, diabetes is a very, very big disease. Very well studied disease. Okay. And you need to study it very, very detailedly. That is what I want to tell, because whichever subject you take, whichever branch you take, it will never leave you. Okay. Right now, right now there are 15 players in diabetes. It's not like single player, only pancreas, liver, and fat. Now we have 15 to 16 players. Okay. So it's a very huge topic. Okay. So basically, adipose tissue level, it works. Thiazolidines. Okay. So PPR gamma agonists. So they decrease the visceral fat. Visceral fat is very bad. Okay. So it will decrease the visceral fat and it will redistribute to other areas. And adipocytes are very important to reduce obesity. Okay. They prevent obesity. So through that activity, at the same time, it will also increase bone marrow fat and decrease the osteoblast. Something like this was mentioned. Okay. So that's why it increases fracture risk. Okay. That is what mentioned in the studies. But all other drugs are neutral. Okay. Only this drug you should not give. But almost all the drugs have shown neutral effect or very mildly useful effect, which is not clinically significant. So for now, still we don't consider. Okay. And then one more thing is hypoglycemia. Hypoglycemia indirectly causes uh, falls, and then you can get fracture. So before concluding that this is due to diabetes, you should rule out whether the impact of fracture is really significant or not, and then rule out osteoporosis, and then do all this. Okay, fine. So I think, yeah, we'll go with the poll questions. This is for the audience, and then if they don't answer, Priyamada can answer. Just to know whether you understood. See, from every hour what you study from class, I want you to take at least some 2, 3, 4 points. I'm sure you will not be able to take everything, but 3, 4 points will change your life. This is what my professors used to tell. So I want to know whether you have taken some lessons from here of 1 hour you spent quality time. Yeah. Question 1, like, Priyamada, can you read question for me?
Yes, sir. So, question 1 is, in a patient with type 2 diabetes mellitus and osteopenia, which diabetes drug would you preferentially choose? Sitagliptin, pioglitazone, SGLT2 inhibitor, or sulfonylurea?
Yeah. Think for 20 seconds. Okay. And then put up in the chart. And who is dare enough to answer, you can open up and tell why you chose that answer. And I'm not going to scold you or anything. You can just for healthy learning. Yeah, answer is correct. Like, can you explain? What is his name? Who answered? Someone answered. I don't know. I'm not able to see the chart. Yeah, Harsha. Harsha, can you tell why? Or Pranav? Why sitagliptin? Why not others? So I know that you heard what we did last 1 hour. See, in entrance exams is easy to answer, but whether you really have subject or not is not checked in entrance exams, right? So I want to be even more better. Priyamada, can you tell? I think they're shy.
So like we discussed, we'll use sitagliptin.
No, you rule out other options before ruling in that. You rule out why.
Pioglitazone we won't use because, like we just
Yeah,
discussed, it's PPA gamma activator. So that's why
yeah,
the bone marrow fat will increase and increased risk of falls.
yeah,
Sulfonylurea is also we won't use because this will cause hypoglycemia leading to falls, and the falls could lead to fractures.
yeah,
SGLT2 inhibitors will also have SGLT2 inhibitors can again decrease bone mineral density because of decreased bone quantity, either that or because of hypoglycemia, sir.
See, whenever you remember one thing in mind, okay? Whenever you answer such questions, you should be clinically oriented, not statistically. You only don't know clinically significant. So you may have so many theories, but whether it is given in Harrison is most important. Harrison only gives if it is clinically relevant. So SGLT2 inhibitor actually it is it's neutral to the bone. There may be mechanisms. I may tell something, but whether it is really clinically proven or not is one thing. I told you, other than pliaglutism, all are neutral. Very easy to remember. But SGLT inhibitors again very mild they told. But so you may choose sitagliptin because it at least preserves. It will not worsen. From few studies it has shown it will preserve. So you may choose sitagliptin or SGLT2 inhibitors. Okay. So it is up to your choice. So that is the thing. Next. Yeah, it is only for others. Like it's not for Priyamada, she'll know definitely. Can anyone you can put in the chat which bone site showed significant preservation in this study? Yeah, yeah, fine. So usually like whatever like most of the side effects from diabetic drugs they have shown hip fractures as the major side effect. Okay, so you just remember that is what it is checked. Okay, so this next one, most likely mechanism for sitagliptin's effect on bone. One question up, please. Oh yeah, fine. This is there. Yeah, third question. It is there. Yeah, most likely mechanism for sitagliptin effect on bone. Another two questions are left. Be active. Yashas, you can encourage them. Tell them if you have a group to answer. Even if you answer it's wrong or it's okay. Like try it. Give an attempt. See, your friend has done very good job. Definitely she would have prepared a lot. Okay, at least some 8 to 10 hours of time maybe. If so, how much you have taken from her is what I'm testing. Only Asha answered. What about others? Please be interactive. Let's save time. I'm sure Priyamada knows it, but I want others to just answer. Yeah, Priyamada, you can answer. I think your friends are shy.
Sir, so I think someone put it in the chat box. Option
Yeah,
C,
yeah,
modulation of inflammatory cytokines. It does not have any direct effects on osteoblastic differentiation. Reduction in bone resorption markers is not present. However, we did mention that there is decreased bone resorption by suppressing osteoclastic activity, but this is again through calcitonin release from the thyroid C cells. Then the next option is modulation of inflammatory cytokines. So it DPP4 inhibition will reduce the inflammatory signaling like we discussed in the PPT. So it will
yeah,
preserve bone mineral density. Vitamin D enhancement, even in this study, there was no change in vitamin D levels at the baseline.
yeah, fine. Yeah. So diabetes, like type 2 diabetes is an inflammatory state. You should remember that. And whole body is in inflammation. Whereas in type 1 diabetes, only the place, only the organs where antibodies are there, that is inflamed. Like you mentioned it both, like in type 1 diabetes also there is a lot of inflammation, but it's not throughout. Like they can be very normal, just they'll have diabetes. They can come like that also, or they can have multiple endocrine gland involvement like that. But type 2 diabetes is inflammation throughout the body. Okay, fine.
Right, sir.
Yeah. Next, fourth question. This is very important question. Does this study change clinical practice today?
No, sir.
A, B, C. What the chart? B. No, see, I hope you know how to answer MCQ. Should read all options. That is the first thing you did know when you started your +1, +2. A, B, C, three are there. She clearly told no, like selected patient something. Okay. So A is definitely not the answer. B may be correct, but when there is C, B is not correct. Okay. So it is older women with is osteopenia, which may be used. Okay. In selected patients. Or else, why will she select the article? Hmm? So she has spent her time. Yeah. This one, fracture outcomes. Yeah. Around 3 to 5 years, they tell. Okay. And in cancer studies where they check for survival, there will be almost more than like there they check for 10 years, 20 years. Here it is 3 to 5 years. Okay. And this already, it is thiazolide diones. Okay. This already we discussed. I think that's all, no? Yeah. Yeah. This last question is for Priyamvada. Like, if you are the person doing this study, what would you change? Like, don't tell everything. See, it's easy to tell what you will change majorly so that the study is better. This is the last question I want to ask.
Right. So we discussed like a lot of limitations for the study.
Yeah, I have discussed a lot, but like what major thing which you felt you will change if you do this study?
So two things. Number one is they followed up. The follow-up period was only for 1 year. If they had increased the follow-up period to longer, then they could have studied even the bone biomarkers and the other parameters in detail, along with fracture risk, also like you mentioned in the questions. The second one is it has very limited generalizability, sir. It takes into account only women. And I feel like with such limited generalizability, it's not a valuable study. So I would change that as well.
You want to include men also at least.
Yes, sir. And then stratify them into different
Okay.
groups.
So you want to do longer follow-up, you want to include men, then that's all. Anything else?
Off the top of my mind, those two things that I'm able to think of. But sir, in addition, we also see that over here they haven't mentioned diabetes duration, fall risk, and vitamin D or calcium cutoff values. In fact, I'd mentioned this as well. They are
Yeah, yeah.
using yeah. So if someone has chronic vitamin D deficiency, hypocalcemia, we should have cutoff values to include or exclude them in the study. Similarly for diabetes duration.
Yeah, fine. But again, doing study is most tough. Okay. When you start doing study, you'll realize. But anyway, you presented very well. Okay. And can you just give me an example of superiority trial versus non-inferiority trial, like in this context? If you want to do like when do you prefer a superiority trial and when do you prefer a inferiority trial?
Sir, so
Suppose you want to do study, like you want to do on a drug. Okay. When will you choose that you'll do superiority trial and when will you choose that you want to do non-inferiority trial? You know about non-inferiority trial, right?
yes, sir. So you use a superiority trial when you have two things and you want to prove whether like one treatment is better than another treatment. So we can use any placebo or standard treatments that are available. But when you use a non-inferiority trial when it's a new protocol, and this is it's not worse than the standard, but it has fewer side effects. So then we'll use a non-inferiority trial.
You have told the description, like the meaning of superior and non-inferior. But when do you use? Like, for example, I want to check one. I am discovering one new drug. I'll name it my own name, Pradeep. Okay. That is an anti-diabetic drug. I want to compare with standard drug of SGLT2 in dapagliflozin. So will I use superiority trial or non-inferiority trial?
Non-inferiority, sir.
Why?
So one is that it's a new treatment, and secondly that if you when you already have existing standards to treat something, it should be first established that it is not worse than the standards. If it is established that it's not worse, then you can go ahead to do a superiority trial to see if that drug can replace the existing standard.
Yeah. So when already there is effective treatment, okay, for something. So there a drug is properly studied. It's easy and you mind you like it is easier to do non-inferiority trial than superiority trial. Okay. So non-inferiority trial we choose with a standard very well established drug. Okay, so if you prove my drug is currently in market metformin so much money someone is making dapagliflozin. So I also want to make money, let's say. So then I will prove that it is at least equal. So people will start buying like that. Whereas superiority trial, here we don't use placebos. In non-inferiority, if you use placebo, it will become criminal. It's a criminal offense. Okay. So we instead in superiority trial, for example, here bone density. Bone density, there are no much drugs. That's why they chose superiority trial. There they considered with placebo. So they just want to prove it is superior over whatever like placebo. That is what, because I told you like in type 2 diabetes there is no drug which is proven. Okay, you got the point, right?
Yes, sir.
Yeah, fine. Thank you.
Thank you, sir. Before we end the session, does anyone from the audience have any questions? All right, then, if no one has any questions, I'd like to thank everyone for your participation throughout the session. And again, a special thanks to our moderators, Dr. Aradhana ma'am, Dr. Prashant sir, and Dr. Pradeep sir, for your time and valuable insights. We hope that this discussion has been informative and thought provoking. Let's continue to explore and share ideas through more events like this. Thank you all once again, and have a great evening ahead.